Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome to this week's episode of the Healing Pain Podcast. I am your host, Dr. Joe Tatta. It's great to be with you. On today's episode, we're learning how to address cardiovascular disease from a lifestyle medicine physical therapy approach. Heart disease is the number one killer of both men and women. This is a preventable condition, and this is also a reversible condition. As primary care physical therapists and other health professionals, it's our responsibility to screen as well as intervene in everyday practice. As physical therapists, yes, we are movement experts, but we are no longer just movement experts. We are also lifestyle behavior change experts. And that's a good thing because we're not just treating one condition such as arthritis, we're treating comorbid conditions or conditions that occur together, such as arthritis and obesity, or low back pain and diabetes. My guest today is Dr. Nolan Peacock. She's an outpatient physical therapist and the lifestyle medicine clinical coordinator at St. John's Health in Jackson, Wyoming. In her clinical practice, she specializes in the treatment and prevention of chronic lifestyle conditions, such as cardiovascular disease, using a combination of physical therapy, lifestyle tools, and health behavior change interventions. On today's episode, we discuss primary care, prevention, and health and wellness, as well as the evaluation, treatment, and management of cardiovascular disease in physical therapy practice. Dr. Peacock did write the section on cardiovascular disease in the textbook Integrative and Lifestyle Medicine in Physical Therapy. You can find that now on Amazon or by going directly to the publisher at optp.com. Okay, without further ado, let's begin and let's meet Dr. Nolan Peacock and learn about a lifestyle approach to treating cardiovascular disease. Hi there, Nola. Welcome to the podcast. It's great to have you here.
Thanks, Joe. It's a pleasure to be here with you.
I'm excited to speak with an integrative physical therapist and learn about all the work that you're doing in practice and how you've been able to really weave in all these interventions together to help people with cardiovascular disease and to help our older populations live a more active life. I think the work you're doing as a physical therapist is a really great model for younger physical therapists, and maybe physical therapists are interested in kind of changing a little bit of what they do in practice. Tell us where you currently are in your practice and how you got started in the work that you're doing.
You bet. So I presently practice in a small community hospital in a rural town in Wyoming. I have the opportunity to work in an outpatient setting, and the predominant work that I do is with patients that have all kinds of cardiovascular disease. I do a little bit of other work that has to do with the aging adult, but most of my days are spent in the trenches working with people trying to prevent and treat cardiovascular disease. In addition to doctor of physical therapy, I have my board certification in geriatric physical therapy, which has been a super great help to the work that I do day in and day out. I'm also a national board certified health coach, which I lean on every single day, every conversation with every patient to help improve the care that I deliver. And on top of that, I'm a board certified diplomat of the American College of Lifestyle Medicine, which blends in nicely with what I do as well.
Great. So when you first, as a physical therapist, as you start talking about cardiovascular disease, a lot of PTs probably are just thinking about maybe a more traditional model where they're embedded within like a cardiopulmonary rehabilitation setting and helping people recover from things like coronary artery bypass surgeries and things like that. But it sounds like what you're doing is actually different because you're in more of an outpatient setting. So there's a bit of there's more of a preventative as well as an intervention based to what you do.
I would say that half of my time is spent in a more traditional cardiopulmonary rehab. It might appear like a traditional cardiac rehab program, phase 2 in the outpatient setting. But then the second half of my day is indeed focused almost entirely on primary prevention. We started a new program at my hospital, lifestyle medicine. And the intention of that program is for primary care providers, cardiologists, whomever to refer to the program patients that they are concerned are headed down the road of developing cardiovascular disease. And so that's the point in which I intervene and talk about all of the different ways that integrative and lifestyle medicine can help them prevent ending up on my schedule in the formal rehab program. So I do both, which is wonderful. I love it.
I love that. So that's really a nice use of our healthcare system, I think.
Absolutely.
Before people get way too down that pathway on sick care, and they need, surgery in this case, or maybe, persistent pharmaceutical interventions. It's how can we intervene and prevent, delay, or oftentimes reverse what has happened to someone due to poor lifestyle choices or lifestyle habits, so to speak.
Yes, one of my favorite conversations that I love to have, and I had it just yesterday morning, a patient called, 50-year-old man, that this is such a crazy story. He was having breathing difficulties following COVID, and he had some diagnostics done for his lungs. But in doing that workup, it was discovered that he had significant coronary artery calcification, significant. He, in his own words, said, COVID saved my life, because he never would have known about this had he not been following up on COVID care. So he is so perfect. He is so motivated to make some lifestyle changes to decrease his risk for cardiovascular disease. And I said to him, this approach can manage, treat, and sometimes even reverse heart disease. Mm-hmm. And he was pretty excited to hear about that.
That word reverse is not one we use too frequently in healthcare in general. And in physical therapy, I don't think we use that word. I think we should use it more to give people just kind of to help them imagine what the possibilities are. Because so often people are told you're going to have to manage this condition, which we know there is an aspect that of chronic disease management that we have to help people with. But the idea of reversing a condition is something that's really new. And obviously the lifestyle and health promoting benefits that we're talking about really fit into that model. And I also think as providers, we really have those skills and interventions and the time to work with people where oftentimes, let's say maybe a primary care physician doesn't necessarily have that time.
So I think that word reversal is so powerful, and boy, does it get patients' attention. They really want to know more. And I would say that the two circumstances in which I use that most common is with cardiovascular disease, and in particular, heart disease, and with diabetes. And it is such a nice thing to be able to say to patients that, yes, we can help you treat this, manage it, live with it. But if you really want to commit to making some changes that are simple, not always easy, but they're simple, you can indeed reverse the beginnings of heart disease. So it's the kind of thing that gets me really excited about what I do every day.
Physical therapists are working more and more in primary care practice settings. They're using more integrative interventions, lifestyle-based interventions. The book that you contributed to, which is called Integrative and Lifestyle Medicine and Physical Therapy, which everyone can check out on the OPTP website. Nola wrote a portion of the chapter on obesity, diabetes, and cardiovascular disease, specifically the cardiovascular disease portion. If you're talking to, let's say, I know you just recently lectured at CSM and you did a great workshop there. If you're talking to physical therapists who have the opportunity to work in a primary care practice setting, what advice do you have for them with regard to screening, examining, and intervening when it comes to cardiovascular disease specifically?
This question brings up a really good point. So heart disease is the number one killer of men and women, of all Americans. It's a big deal. I don't know that it always gets the attention that potentially it should get. But what that says to me as a clinician is that every person that walks through my door, I need to be screening at the bare minimum, blood pressures, getting a family history, basic, easy questions and screening tools that don't take a lot of time. But for example, if I see a patient for osteoporosis, I'm screening for cardiovascular disease. I believe that's sort of my role in bridging physical therapy into the primary care arena, that we need to assume that these people presented to us might have some risk factors for heart disease. So really a critical point. Thank you for bringing that up. I think about that all the time. Everyone that walks in my door, it's my responsibility to screen for that.
So let's take an example. So for example, as a physical therapist, do you screen for factors related to metabolic syndrome?
I do. I take a really thorough history about, of course, like I mentioned, family history, but personal history and other comorbidities, diabetes, hypertension, all these things that can partner in the development of heart disease. Think that we can't miss any of these. And it's amazing how many patients will say to me, I'll ask them perhaps, what was your last A1C? And they don't know. And so there's an opportunity for us to educate about, your blood sugar management is really important for the prevention of heart disease and all other cardiovascular diseases. So I do feel like it's an important part of what we do. And again, it doesn't take a lot of time. I think sometimes it pushes us as physical therapists maybe a little bit out of what we're doing. If we're working, say, for example, in an orthopedic setting or a women's health setting, it may not be the first thing that comes to our minds, but I think it ought to be one of the top priorities that we're covering.
Right. So as a physical therapist, taking a blood pressure, heart rate, respiratory rate, we're comfortable with that, right?
Mm-hmm.
People would identify that as fitting squarely in our scope of practice.
Sure.
I mentioned the word metabolic syndrome, and then you mentioned blood sugar. Mm-hmm. So looking at, let's say, fasting blood sugar, looking at A1C, those are things that we do learn about in school. But oftentimes those habits aren't necessarily carried over into practice unless you wind up in a specialty practice.
Right.
Maybe like yours, which is kind of specializing in cardiovascular disease. But those skills and principles can be carried over really to any aspect of PT practice, right?
Sure. And, this brings up the point that perhaps my focus is on cardiovascular disease and their sequelae, but I also screen for musculoskeletal issues and for example, urinary continence, and as I would screen for mental health issues. So I cannot just look at a person with a heart. It's everything altogether. And maybe that's where, we love specialties and they're great and they do wonderful things, but we can't miss the fact that we are treating the entire person and indeed the environment in which they exist, their social, economic statuses. We have to have respect for all of these things, in addition for screening for things that aren't maybe exactly what the person is seeing us for.
You mentioned in your practice, you are working with patients both with maybe, let's say, a cardiovascular disease history, but you're also seeing other orthopedic type conditions and injuries that might be more typical of a PT practice. How do you see this kind of what you do really? When I look at what you do and I know your work, it really starts to bridge a gap between, as we mentioned, primary care physical therapy, looking at cardiovascular disease, and then looking at older populations and aging and how we can help promote physical activity and other wellness type interventions in that aging population, which sometimes people feel like, well, as I get older, I should be less active, or I should have pain, or I'm just going to develop thin bones. You hear these things all the time. So how does your work start to kind of connect those two together?
So I think where the dots connect in my practice is that I see what I'm doing as promoting active aging. And my definition of active aging is being able to optimize and maximize the things that every aging adult, or not even aging adult, all of us want to do, whether it's social, it's recreational, occupational, and physical. All of these things play into our experience of aging in an active way. Keep doing the things that are important to us and the priorities that are meaningful to us. So whether that means addressing cardiovascular disease as a primary diagnosis or a secondary diagnosis is critical, along with other musculoskeletal concerns or risk and fall prevention. Those kinds of things that I think support the experience of active aging. That's where I think my practice comes all together, is that it's taking all the pieces of these different areas, addressing them so that the aging adult can, live the fullest life. And I think I'm really lucky I get to practice in a setting where people are very physically active into their later years, and they sometimes demand some pretty amazing things of their bodies into their 80s. I've seen patients out skiing on the hill or out hiking on the trails, and they are in their late 80s, and they just expect that. So to me, that's the active aging piece that kind of pulls all the pieces together that you were asking about.
Because you work and live in a ski town. So
I do.
They grow up skiing, right?
I did. Oh, yeah, absolutely. And that's the culture in which I practice, that There is an expectation that when I turn 60, I'm not done skiing. People expect to keep doing these things and, climbing and mountaineering and backpacking. And I love that because that to me is part of the definition of active aging.
It's interesting because there's a social aspect there, because in that town, there's really this like social mindset, if you will, that just because I'm getting older and moving along in my years doesn't mean that I won't be skiing.
Exactly.
Or doesn't mean I won't be hiking.
Exactly. And I think that bleeds over into a lot of the work that I do. I do a lot of outreach into the community, education and presentations and speeches and talks and things. And a lot of it is geared towards how do we keep people doing what they love to do? And that can be physical, hiking, skiing, climbing, all those good things. But the social aspect is massive. Everybody wants to be with their friends or their loved ones or their community doing things that they enjoy and that make them feel that they're doing important things to them. So that is definitely a point not to be missed, that the physical functioning that we focus on as physical therapists has such an important social piece and a quality of life piece, without a doubt.
That's really well said. So the physical aspect of what we promote, because people look at physical therapists as being movement experts, but moving your body extends beyond the clinical setting. Being able to move your body means you can now move throughout your life and engage with the things you want to engage with.
Absolutely. And you can look at this also maybe on two sides of the same coin, that as physical therapists, we are rehabilitating people to be able to do these things that they want. And I'm doing that, but I'm also coming from the other side and preventing these problems from happening in the first place so that they can continue to do what they want to do, with, again, a focus on cardiovascular disease, but also musculoskeletal issues, maintaining a good body weight and exercising, range of motion and strengthening, all those things support that same principle.
So if a patient came into your clinic and said, Dr. Smith just diagnosed me with heart disease, and he said, I don't need surgery yet, but if I start to change some things in my life, I should be able to prevent this. And I've also noticed that I've started to slow down a little bit. I don't walk as fast and I'm not as strong on the ski slopes. What can I do about it? What would be the lifestyle interventions that you recommend to a patient who comes in with those questions and those expectations that they'd like to overcome?
Well, the first thing I really try to do is to get a sense of where that person is. Are they feeling motivated? Are they fearful? Are they, just filled with dread? Where are they at? Where are they at in the processing of this information? I think that sometimes fear is a motivator, but it's not always the motivator that I prefer to work with. I want to work with somebody where they're really wrapped their head around what's going on. They feel like what they do can make a difference. Once I know that a person is there, or I help them kind of get there, saying that, this isn't just happening to you, you actually can exert some effort and make a change on this, then that patient feels like, okay, I'm in the driver's seat and I can make some changes. And I spend a lot of time talking with these patients about, there are non-modifiable risk factors for heart disease. We note those, but we don't pay attention to them because there's nothing we can do. But fortunately, there's this huge category of modifiable risk factors. That's where I turn my attention to with that new patient that comes to see me saying, I've got this new diagnosis, what do I do? And then I walk through everything that they have in their arsenal. I'll talk a lot about nutrition, of course, within the scope of my training, but there are some powerful pieces of information there that people often don't know about. Spend a lot of time talking about stress and stress mitigation rather than stress reduction. Stress is a part of life, but what we can do to mitigate that stress and the effects of it. Talk a lot about other comorbidities, like we mentioned, diabetes. I look at their labs and go over the labs with them so that they understand how those pieces play into it. Talk about other controllable risk factors like hypertension. And then once I've kind of laid that foundation, then as a physical therapist, I spend the bulk of my time really talking about, okay, what kind of exercise program can we tailor together that will help to, improve your strength, make you feel more confident in what you're doing, improve your endurance, all those things. And how can we angle that towards a treatment, prevention, and reversal of the disease?
Excellent. So you mentioned, it sounds like there's a lot of educating that you're doing. And we know that there's a lot of education that we help people with regard to their care. Have you arrived at the point yet in your practice, let's say, where you just spend an entire session working on so some people say education, some people say counseling. I actually like the word counseling better. They're very similar to me. They're almost the same thing. They really are the same thing. are you there yet where you're like, I'm just going to spend a whole session counseling on, we can pick a topic because obviously lifestyle medicine is quite broad, but there are a lot of physical therapists that think if I don't do manual therapy and therapeutic exercise during the session, then either one, didn't do my job, or two, like I'm in some, weird in between point. I don't know who I am as a professional. Where have you arrived at in your practice with that?
So I would add to your list patient education, patient counseling, and coaching. So I spend a huge portion of my time with patients coaching. So a blending of counseling, education, and coaching. And yes, there are sessions where the majority of what I'm doing is providing tools and training and knowledge and education counseling for the patient so they can take what they've learned and go do it themselves. So maybe my little trick with this is that I may not be doing manual therapy or other kind of hands-on things, but I can certainly get a patient on a treadmill or on a stationary bike, or we can be working on balance things where they're working on something physical and I'm talking away and giving them the information that I feel like they need. So I know multitasking isn't supposed to be healthy for us, but I pretty much do it all day long. Yeah, but I do. I would say that the value that I provide for my patients is the training, education, counseling, coaching that I can do for them.
Right. That's the most valuable piece that we can offer people.
Yeah.
Right.
But I have to say, 20 years ago, had you asked me that, I don't think I would have said that.
Yeah.
I think I would have felt like I needed to do something to the patient. And now I'm comfortable providing information that they can go and do. It's a shift in roles, I think, for us as physical therapists.
Yeah, it's definitely a shift in mindset. As you mentioned, kind of like doing and fixing as a physical therapist versus the counseling and coaching.
Well, and you know what it does for us too, Joe, is that it decreases our potential for burnout.
Yeah.
When I am fixing people, or if what I didn't help them, it's my fault. That's a major recipe for burnout. When I'm providing them what they need, it's evidence-based. Everything I teach my patients is evidence-based. I can back it up. They get sick of me talking about studies. But when we shift our role from the fixer to the supporter, the coach, the trainer, the educator, it changes our work tremendously. And I love it.
Right. Because what you're talking about with regard to cardiovascular disease especially is there's a strong aspect of health behavior change, which really is the underlying aim in everything you're doing as a physical therapist, whether you're working with someone with just cardiovascular disease and an orthopedic injury, or just an orthopedic injury.
Absolutely. And I strongly feel that maybe not we as a profession, but those of my colleagues that practice in this mindset of integrative and lifestyle medicine, is that we have shifted from the expert that just knows it all, does it all, prescribes it, it's mandated, it's enforced, to this role of supportive, of figuring out where the patient is, what they want, what's important to them, and how to get there with evidence-based practices. But it takes us a little bit out of the driver's seat. We're now more the co-pilot. And I firmly believe, and research will back me up, that this approach of work has longer lasting changes. We are behavior modification experts, not just movement experts. So I'm both together.
One of the reasons why I love that is because if you go to the APTA website to this day, it still says that physical therapists are movement experts. Mm-hmm. And a lot of the work that I do through my podcasts and other resources that I have out there, and of course, now people like you are really kind of joining this movement and saying, hey, APTA, let's knock on the door. Let's have a little conversation. We are, of course, concerned about movement. Movement and physical activity is, well within what we do. But ultimately, we're after changing someone's health.
For the long run, right? And that's where I think the power of what we do comes in. It's clearly a cost savings. It improves quality of life, but it also empowers the patient to feel like they can do something. We started our conversation. I gave you the example of the man that was referred to me that had, calcification of his coronary arteries. He just felt like it was there was nothing that he could do. When he heard there was even a little bit of a glimmer of, maybe if I do something in a particular way, I can help myself to improve and get better. He's sold on this for life. He'll do it for always because he feels empowered to do so for the long run.
So the chapter that you wrote in the book, Integrative and Lifestyle Medicine in Physical Therapy, you have two other co-authors with you. Rupal Patel, who did the part on diabetes management.
Yes.
And Erica Merriweather, who did the part on obesity care.
Yes.
What would you like to see happen with this? So obviously this is a textbook for PT education and practice. It's going to be utilized in PT schools. It's going to be utilized in PT private practice. How would you like to see your chapter utilized by the profession broadly? And when we talk about the profession, we could talk about education, we could talk about clinical practice, we can talk about research, but how would you like to see the profession pick up this chapter and say, lifestyle medicine for cardiovascular disease? How should they kind of run with that material?
What I love about the chapter that we authored is that it blends three really important coexisting morbidities that, play with each other, not always nicely, and lead to heart disease. Mm. It is a great example, a small little isolated example of what physical therapy can be, that we are not just treating diabetes in a silo. We are not just treating, osteoarthritis in a silo. It is comprehensive and it's holistic and it's the whole person. So this is where I think that lifestyle medicine comes in beautifully. Lifestyle medicine is not just physical. It is, but it's also stress related. It's positive social connections. It's avoiding risky substances. There's more to it than just one isolated diagnosis. I don't think that we can treat patients appropriately when we're treating just the diagnosis that comes with the referral, or that the patient, the first thing that comes out of their mouth in our exam and our eval. So I love this chapter because it brings three really important pieces together and shows beautifully how the three can come together to support improvements and benefit each of the areas.
Because there are overlaps in those three diagnoses that we just mentioned: obesity, cardiovascular disease, and diabetes. So when you apply, or when oftentimes people look at like targeting a disease in practice. And I'm like, as you mentioned, you don't really just target one thing. Like if you're sending a patient to me for cardiovascular disease, the tools and principles and skills that I have, when I apply them, yes, will help someone overcome and reverse their cardiovascular disease, but it's also going to broadly apply to diabetes and
sure.
helping them maintain a healthy weight and help with their physical function, and maybe even help with their mental well-being.
Well, a great example of that is if someone's referred to me, say they've had some falls recently, or their primary care provider is concerned about their fall risk. They come through the door, the first thing on my mind is, fall assessment, fall risk assessment, and fall reduction. But then it spirals to all the other things. What is going on here? Is there a chronic pain issue? Is there a strength deficit? Is there something else going on that's not the obvious thing that's leading to this problem? And that, again, is where I think physical therapy becomes really fun, because we get to investigate the whole picture and not just target in on that one diagnosis that we think we're treating, because we should be, in my opinion, treating the whole person.
So if there's a PT out there who's listening, other than reading your chapter in the book, which we'll point people to, you can purchase the book on optp.com. I'll link to it in the show notes. If there's a PT who just wants to start, so they don't want to kind of jump right in and convert their whole practice into, let's say, a cardiovascular disease rehabilitation center, but just wanted to start with, addressing, let's say, cardiovascular disease and in the patient population they're seeing. Maybe they're in a neurologic practice, or maybe they're in a women's health practice. What kind of recommendations do you have for them?
Really important point I think that can be made here is that every patient that you see, your patient with Parkinson's, your patient with a spinal cord injury, when you are doing your screening as a physical therapist and you're looking at some key indicators, respiratory rate, pulse, blood pressure, if you find something that's out of the accepted norm for that demographic, follow up on it. Don't just say, oh, wow, their blood pressure is 130/90 and move on. Mm-hmm. Take a few moments, follow up on that with the patient, the family member, the caregiver, whomever. And then I personally think that it should be followed up with the referral source. If it's self-referral, that's a little different, but it needs to be followed up on. Make a connection with the primary care provider or the specialist that sent that person to you. Don't just let it be, oh, well, I screened for this. Proper screening and good physical therapy care is to screen, document, but then do something with it. So I think that's an easy way to kind of dip your toes in, extending beyond your silo of care that you provide and branching it out to, for example, cardiovascular disease. Super easy way to do it. And frankly, it's what we should do.
So if a patient comes in with, let's say, chronic lower back pain, and you screen and you find they also have hypertension and their blood sugar is a little high, maybe it's 100, let's say. Are you referring them back to their primary care? Or are you saying, or are you kind of opening up the conversation and saying, are you aware you have these risk factors? And they might say maybe yes, and then maybe referring them on to, let's say, a cardiologist or a cardiac specialist.
So it can be a lot of different approaches. Normally what I do, always I turn it back on the patient and say, are you aware of this? Do you understand this? Tell me more about what you know. And then I'm quiet for a minute and try to hear what they have to say about their understanding. If it seems like they've kind of got a plan in place, oh yes, I just found out about this. I'm working with my doctor on this. Okay, that's great. But more often than not, I will reach out to the primary care provider or whomever the referral source was. I'll make that phone call and say, hey, did you know? This is one of the beauties of an electronic health record, right? Is that I can look in their chart and say, whoa, they've never had, nobody's ever talked with them about their elevated blood sugars. So I will take that extra step. And I understand it takes time and it takes a little bit more of an effort, but I do feel like that to me is the practice of good care, holistic good care.
Yeah, because I think the take-home message there is just because someone, let's say, maybe you have access to an electronic health record in a big medical system, or maybe someone brings in their lab results, just because they've seen a physician that's identified, let's say, high blood sugar or hypertension, doesn't mean they've received effective counseling on that.
Absolutely. And this goes back to what we were talking about earlier. If we want to dip our toes into primary practice, we better get really comfortable with looking at labs, asking follow-up questions, and getting that information, and then deciding what's proper to do with it. So I absolutely agree with you. Definitely.
No, it's been great speaking with you today. I know everyone's going to love reading the chapter that you wrote on cardiovascular disease in the book, Lifestyle Medicine and Physical Therapy. You can all find that on the OPTP website. I'll link to it in the show notes. You can, of course, find it at the Integrative Pain Science Institute as well. I'll link to it there. If people want to follow you and your work, how can they learn more about you?
The best way to find me is at stjohns.health, and that's spelled STJOHNS.health. And in a tab that pops up, you'll see a lifestyle medicine tab. Click on that and you'll learn a little bit more about the health coaching that we're offering and the lifestyle medicine that I'm doing. And you can follow up with me there.
Great. So I'll link to that in the show notes so you can follow all the great work that Nola is doing in physical therapy as well as integrative and lifestyle medicine. I ask you at the end of every show to share this information with your friends and colleagues who are interested in cardiovascular disease, active aging, integrative medicine, and lifestyle medicine. Share it on Facebook, LinkedIn, Twitter. Hey, and if you're on Instagram, take a screenshot of this podcast and tag me in it, and I'll make sure to tag you back. I'm Dr. Joe Tatta. It's been a pleasure being here with you, and I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.